and I'm privileged to host Dr. Carrier today. He is the head of the Division of Hematology in the Department of Medicine at the Ottawa Hospital and a professor in the Faculty of Medicine, University of Ottawa, and a senior scientist in the Clinical Epidemiology Program of the Ottawa Hospital Research Institute. Thank you, Dr. Carrier, for joining us this morning.
Thank you so much for having me. It's a great pleasure to be discussing cancer-associated thrombosis today, and I meant for this talk to be very informal. So things are controversial at best. So please feel free to interrupt and ask questions. And Dr. Bat was kind enough to send me a few cases and a few questions. So we'll go through them as long as we can, and if we have to stop, then we can stop 5 or 10 minutes early and just generate questions to the Q&A. So the first case is 65-year-old male patient with newly diagnosed biopsy-confirmed metastatic pancreatic adenocarcinoma with liver involvement, and hematology is consulted about prophylactic anticoagulation recommendation. Is the patient at high risk or not of a VTE, but also potential complication from anticoagulation, such as bleeding? Is the risk-benefit ratio favorable? And if so, then should we initiate anticoagulation at prophylactic dose? Should it be low-mech weight heparin like enoxaparin? Should it be a directal anticoagulant? And when to do what, more or less? What are the factors to consider? So the first question that I was asked to discuss a little bit is, how do you define cancer-associated thrombosis, and can we briefly allude to the pathogenesis of cancer-associated thrombosis? And today we'll be focusing on venous disease only. So when we're referring to cancer-associated thrombosis, it's really a general term and really reflects cancer-associated venous thromboembolic disease. But there's more and more attention to cancer-associated arterial thrombosis as well. But so to simplify for the discussion, we'll talk about cancer-associated venous disease, so lower limb deep vein thrombosis, pulmonary embolism, upper extremity deep vein thrombosis, unusual site thrombosis. And the term cancer is slightly controversial. So what is the International Society of Thrombosis Hemostasis definition of active cancer that goes into the definition of cancer-associated thrombosis? Well, active cancer is a cancer that is diagnosed within the previous 6 months, that is recurrent, regionally advanced, or metastatic in nature, for which treatment had been administered within 6 months, or an hematological type of cancer that is not in complete remission. So when we refer to cancer-associated thrombosis during the discussion, we're really referring to that. And as you can see on the right-hand side, regarding the pathogenesis of cancer-associated thrombosis, multiple overlapping and interacting pathways explain the increased incidence of both really arterial and venous thromboembolic disease in patients with cancer. Mechanism of CAT, or cancer-associated thrombosis, will include, as you can see, activation of the coagulation system, dysregulation of the fibrinolytic system, inflammation, and cytokine production. I'll focus a little bit on tissue factor because it's an important trigger of the hypercoagulability associated with CAT, and an important thing to understand when we think about the new anticoagulants like inhibition of factor 11, factor 11A, that is associated with cancer-associated thrombosis. So as you can see on the figure, tissue factor initiate the extrinsic pathway of the coagulation cascade, which creating a complex with factor 7, which will promote the activation of factor 10 and formation of factor 10A. Tumor cells per se will express tissue factor, and some of the tumor cells will also release extracellular vesicle, which are expressing tissue factor, which is leading to thrombosis and thrombin generation and fibrin formation. PI1, so PI1 inhibits tissue plasminogen activation and urokinase, promoting the fat formation of fibrin. So a lot of the different tumor cells will have increased plasma level of PI1, for example, brain and lung and pancreas, which leads to dysregulation of the fibrinolytic system. And inflammation can stimulate neutrophils. The interleukin, for example, the endothelial cell damage can lead to that. And that leads to induction of neutrophils extracellular cellular traps or nets, which is used as a scaffold for platelets and other procoagulant molecules. And nets can also directly activate platelets, leading to further thrombosis by thrombin generation. And as you can see here, the ATVB narrative review is quite good if you're interested in learning more about the pathogenesis of cancer-associated thrombosis. But this is, in a nutshell, what is the underlying mechanism. The next question I was asked to address is, for this particular patient, which scoring systems is or are helpful and for which type? And this is a controversial question for which there are no right answer, but I'll talk to you about a specific risk score called the corona risk score. And the corona risk score has pros and cons, advantages and disadvantages. The most important advantage is it's really simple, and you have everything you need when you're initiating chemotherapy in order to stratify patients according to their underlying risk of having venous thromboembolic disease. So you just really need to have the tumor type, CBC at the time of initiating chemotherapy. So you need to focus on white blood cell count, hemoglobin or hematocrit, platelet count, and body mass index. There's pros and cons to the corona risk score, but it's been extensively validated externally, used in clinical trials. But when you look at specific tumor type, it may not be as sensitive or specific or performing well to stratify patients. And therefore, there's been a number of additional scores that have added additional elements to the corona risk score. It can be biomarkers, for example, other patient or chemo-related characteristics or factors. Other scores like the OncoTev score and the CompassCat have been trying to add completely different things or genetic markers associated with it. But part of these issues with the other scores is, although sometimes they've been derived and validated in external cohorts, they've never been used by clinicians to change clinical practice like it is for the corona risk score. So although there's advantages or disadvantages to the corona risk score, it's really the only score that is really for prime time use in clinical practice. So as I mentioned, you use the site of primary tumors as CBC prior to chemotherapy, body mass index, and you calculate the number of points associated with different variables. And then you stratify your patients according to the underlying risk. And you can see here on the right-hand side that this is a validation of the corona risk score in the Vienna CAT prospective cohort study, that if you have a corona risk score of 2 or more, you have an underlying risk of having venous thromboembolic disease of about 10%, so 1 in 10 patients. This is huge. This is much more than other thresholds that we use to initiate primary thromboprophylaxis in other patient population like post-hip and knee arthroplasty, or, for example, hospitalized patients with medical illness. And therefore, that's a threshold that people thought that we should use in order to decide if patients should receive some form of thromboprophylaxis or not. And you can see that if your corona risk score that is high, so that's 3 or more points, then the underlying risk of having VT in the next 6 months is about 17% or 1 in 5 patients. So as I mentioned, the corona risk score have been externally validated in multiple patient population. There's a recent individual patient level meta-analysis that was published, including 3,300 patients. And they looked at the different stratification of the risk score. If you have a low corona risk score, then the underlying risk or the 6 months cumulative incidence of having VTE is about 4.1%. For intermediate risk is 6.8%, and for high risk or 3 or more, it was about 10.5%. If you decotomize the score to make it more clinician friendly, if you decotomize it to high risk or non-high risk, you can see here that the odds ratio of having venous thromboembolic complication in the next 6 months about 1.6. And what's interesting with this individual patient meta-analysis is it also looked at specific tumor type, and it looks like for lung cancer, the corona risk score is not very good to dichotomize patients according to their underlying risk of VTE. And if you look at lung cancer patients with a corona score of 3 or more versus non-high risk, the odds ratio was only 1.1. But when you remove these patients from the overall patient population, the coronary risk score performs much better with an odds ratio of 3.2. So maybe the underlying thinking is that we should use the coronary risk score for a majority of patients to screen them according to their underlying risk of having VTE. But for patients with lung cancer, maybe additional data is required in order to stratify the score a little bit better. And when I was saying that it's the only score that is ready for prime time use is based on this here. So all the other scores sometimes have been shown to be more specific, sensitive, performing better, but they've never been used in clinical practice to tailor primary trauma prophylaxis in the patient population with cancer. So you can see here a systematic review and meta-analysis, again published in Blood in 2020, showing that when you look at different outcomes, venous thromboembolic disease, major bleeding, and overall mortality, stratified by patients that are intermediate to high risk or high risk of having venous thromboembolic disease based on the coronary risk score, you have number needed to treat and number needed to harm that are helpful for clinicians to decide on the risk-benefit ratio. Is it worthwhile to initiate anticoagulation at prophylactic dosing in this setting? And you can see here that if you have a coronary score of 2 or more, the number needed to treat is about 25. If you have a coronary score of 3 or more, the number needed to treat is about 17. And that does not seem to be associated with a significantly higher risk of bleeding, but number needed to harm, are listed here and important to keep in mind and may differ depending on if you decide to use low molecular weight heparin or a directal anticoagulant. Interestingly, mortality seems to be favoring the use of primary trauma prophylaxis. Obviously, wide confidence interval. None of these studies were powered to see any difference in overall mortality, but it's hypothesis generating and can be conflicted with a number of different factors, of course. So this is really how we assess, or I think how we could assess the underlying risk of VTE. But then the next question is, what do we assess the risk of bleeding? Because, you know, we mentioned that major bleeding may be a complication of primary trauma prophylaxis. And is there any tools that clinicians could use to assess bleeding properly? And unfortunately, there's no tools really to identify patients with cancer receiving prophylactic dosing of anticoagulants. Kristen Sanfilippo from WashU has been using the AVERT and Cassini data to try to come up with risk predictors of bleeding for patients receiving primary trauma prophylaxis, but that has not yet been published and peer reviewed. So the only thing we have for the time being is risk scores or clinical decision rules that are used to predict bleeding in patients receiving full dose of anticoagulation. And if you can see, a number of clinical prediction rules have been used for patients with VTE, ACCP VTE, Einstein has bled, the Riete VTE bleed, which is the most recent one that you can see on the right-hand side. These rules are great. They can highlight different variables that are associated with higher risk of bleeding complication like anemia, prior history of bleeding, renal dysfunction, age. But the problem with them is active cancer is the most important variables the variable that is most likely to correlate with bleeding complications. So when you actually assess them in a patient population with cancer-associated thrombosis, they don't perform very well. And the C statistic is only 0.5 to 0.57, so showing poor calibration. So the next question is, well, do we have clinical decision rules specifically for cancer-associated thrombosis, and would that be helpful? And folks from the Netherlands have tried to do that using the patient population from the Okusai VTE cancer trial that compared low molecular weight heparin to edoxaban for patients with cancer-associated thrombosis. And you can see here that they came up with some variables that are specific to patients with cancer. So it looks like patients with cancer, with regional advanced or metastatic cancer, GU cancer, creatinine clearance that showed dysfunction, recent use of anti-cancer therapy with GI toxicity, age, and GI cancer receiving DOAC, in this particular case, edoxaban. These patients receiving full dose or therapeutic dose of anticoagulation may be at higher risk of having clinically relevant bleeding. So a combination of major bleeding and clinically relevant non-major bleeding. So this is a step in the right direction. At least we have cancer-associated variables that we can see, that we can maybe mitigate to help avoid having too much bleeding complication. But it's important to keep in mind that it's only for therapeutic dosing. And therefore, we don't have the same type of data or granular data for prophylactic dosing. So I think it's part of the issue why primary trauma prophylaxis is not very well used, is although there's good data showing efficacy, clinical practice guidelines, and we'll come back to that, is showing you can use it in high-risk patients at low risk of bleeding, but clinicians don't have any tools to identify patients at low risk of bleeding. For you and I doing this on a regular basis, it's easy, but for medical oncologists only seeing solid tumor, it may be a different issue, and they may not be as comfortable making these types of decisions. So the next question is, when do you consider thromboprophylaxis anticoagulation? I think this 65-year-old male that we presented earlier with metastatic pancreatic adenocarcinoma, even if we don't have a CBC or BMI, just based on tumor type, you would have 2 points. So we know his underlying risk of having VT complication is in the next 6 months is at least 10%. And when we did look at the systematic review and we balanced the risks and benefit of thromboprophylaxis, we saw a number needed to treat of 25, a number needed to harm of 1,000. Keep in mind that the number needed to harm may be different depending if you're using thromboprophylaxis with enoxaparin or low-molecular weight heparin or a direct anticoagulant like apixaban or rivaroxaban. Number needed to harm on a 2 randomized controlled trial may be closer to 100 instead of 1,000. But when we put all the data together, it's about 1,000 based on this systematic review. So this is what is recommended in clinical practice guidelines. I've put the American Society of Hematology 2021, but it would be the same in the American Society of Clinical Oncology or the NCCN. There's a suggestion of using thromboprophylaxis if your patient is at high risk of thrombosis or coronary risk score of 3 or more. There's a suggestion to consider thromboprophylaxis with a DOAC, but not with low-molecular weight heparin if your coronary risk score is 2 or more. And there's a recommendation not to use any thromboprophylaxis if you have a low-risk patient, simply because you don't want to expose them to higher risk of bleeding complication using pharmacological thromboprophylaxis. So in this particular patient that was shown, I would definitely have a discussion with the patient. Sometimes there's logistical issues. For example, coverage might be a reason, cost might be a reason, maybe a high risk of bleeding complication. But at least given that he's 2 points or more, at least intermediate risk of having VTE, I think he needs some education on the risk, signs, symptoms of DVTs and PEs, because if he has them, he needs to seek medical attention. And you all know that we see a lot of incidental PEs, for example, and when you actually talk to the patient and then ask if they had symptoms, most of them did have symptoms for a while, but they thought it was because of the underlying cancer or the side effect of the chemotherapy. They didn't even know they would be at high risk of having a blood clot in their lungs. So a little bit of education would be desirable. And if possible, in a patient at low risk of bleeding, then I would offer him some thromboprophylaxis. I tend to offer thromboprophylaxis using a direct anticoagulant because adherence and persistence to DOACs is better than low-molecular weight heparin. Cost in my country is certainly lower. It's not yet covered because there's no indication. We'll come back to that, but I would I would do. The next question is, what did we learn from the AVERT and Cassini trials, and how do we explain the difference in outcomes? So as you know, the AVERT and Cassini trials are trials that have randomized patients with at least an intermediate to high risk of having venous thromboembolic complications or coronary score of 2 or more, to prophylactic dosing of direct anticoagulant or placebo for 6 months, and followed patients for 6 months. And you can see they were published in the same journal of the New England Journal, or same number journal of the New England Journal. And this is the editorial that John Keller and Nelly wrote. And I like it because it shows both trials side by side. So if we start with the AVERT trial randomized patients to apixaban 2.5 milligrams POBAD or placebo, followed patients over time. And you can see at the end of the 6 months, if you look at the first line of primary efficacy outcome, The placebo patients had 10% risk of VTE, so exactly where we've been discussing and exactly on target. And patients receiving apixaban had only 4.2%, so a relative risk reduction of a 60%, about a 6% absolute risk difference or absolute risk of having VTE difference. That was not the case in Cassini. So in the placebo group, they had 8.8% risk of VTE. They only had a lower risk of rivaroxaban, about 6%. So they did not reach their primary hypothesis. It was not a positive trials, but when they looked at analysis during the treatment, then they had a statistically significant reduction of about 60%. That was similar. And then when you look at major bleeding on the other side of the coin, if you look at the AVERT trial, there's an increased risk of about 1.8%, but that was the ITT analysis. And maybe if I would have been smarter and it could go back in time, I would have used a non-treatment analysis like all the other trials have been using. And that would have been an absolute difference of 1% that is not statistically significant. And this is what Cassini actually has used. So major bleeding on treatment showed a 1% not statistically significant. And therefore, when you look at the cumulative values altogether, you can see that, there's an absolute difference of about 4% for the risk of VTE and an increased risk of about 1% of bleeding complication when you combine the values together. So the question is well taken. How do you explain the differences in outcome? There's a few differences in the study procedure. So for Cassini, and I'm not sure if you participate in Cassini, you needed to have an ultrasound done prior to randomization. And if you had a positive clot, proximal or distal, then you could not be included we could not be randomized. And that may have led to a selection of low risk group. I don't think it's standard of care in most places to do ultrasound on all patients initiating chemotherapy. I know Cleveland Clinic does it, and maybe the MSK does it to a certain extent, but that may have led to a selection of a low risk group. They also used ultrasound detected DVT as a surrogate outcome measure during the different weeks, week 8, 16, and 24. That may have led to early diagnosis that would have prevented symptomatic differences. And obviously, these were included in the outcome measure. So symptomatic distal ultrasound detected and symptomatic distal and ultrasound detected were included in the outcome of the Cassini trial. And there's differences in tumor types. So Cassini was stratified based on advanced pancreatic cancer to have about 50% that were GI-related cancers, whereas in AVERT, it was mostly lymphoma, gynae, and some GU. So taken together, these two trials are quite complementary in the underlying risk of or representative of different tumor types, but there are certainly differences in study procedures and outcomes that may have led to the difference that we've noticed. So our patient, for different reasons, received education on venous thromboembolic disease, signs, symptoms of PEs and DVTs. He knows to seek medical attention if he has to. He is not started on prophylactic dosing of anticoagulation because of different reasons deemed to be at high risk of bleeding or cost-related reasons. And 6 months later, he shows up to your emergency room or emergency department, bilateral PE, and he's placed on an anticoagulation for indefinite duration because he has metastatic pancreatic cancer, which is the underlying risk why he had the clot to begin with. This will never disappear, and therefore we'll continue anticoagulation for as long as we can until the risk of bleeding outweighs the risk of the intervention. So the first question is, what's your preferred anticoagulation of choice and why? I would have to say that I tend to start almost everybody on a directal anticoagulant. And this is based on systematic review and meta-analysis that was published by people in France, combining the 6 randomized controlled trials that have compared the different low molecular weight heparin, mostly dalteparin, to the different directal anticoagulants. And you can see the efficacy outcome measure on the top. So recurrent VTE, you can see that patients receiving a directal anticoagulant had a lower risk of recurrent event despite anticoagulation, an absolute difference about 3%. And when you look at safety with major bleeding, you can see there was no big difference between the two groups. Low molecular weight heparin 3.7% and a slightly increased, not statistically significant improvement with a directal anticoagulant about 1%. So based on that, you can see that there's a bit more variability in the risk of having major bleeding depending on the trial. Some people say apixaban, as we know, Caravaggio was not associated with a statistically significant increase of major bleeding complication. But keep in mind that we are actually not sure what the reason for that is. Is it because it's a BID medication, so a lower peak, higher trough? That's possible. Keep in mind that, patients were being randomized into Caravaggio for 2 years after we knew that there was an increased risk of major bleeding for patients with GI tumors, randomized in OX-IVT cancer and SELECT-D. So maybe there's some self-selection that happened there. I think overall the DOACs are all more or less the same, and I don't have a strong preference for one over the other from a major bleeding perspective. It was mentioned in the case, there's difference in clinically relevant non-major bleeding. So remember, the major bleeding definition by the ISTH is clinical site bleeding, so fatal event, intracranial hemorrhage, joint, retroperitoneal, and patients that don't meet these criteria but still need to have a medical intervention or seek medical attention, they have a clinically relevant non-major bleeding. And when you compare patients receiving low-molecular weight heparin or DOAC, you can see there's a statistically significant increase in the risk of clinically relevant non-major bleeding in patients receiving a DOAC. And that's really related to patients having gastrointestinal type of bleeding in patients with GI tumors, and hematuria in patients with genitourinary type of tumors, independent of the molecule you're having. So they've seen that in the trials with edoxaban, rivaroxaban, and apixaban. And therefore, that's the rationale for clinical practice guidelines to say, well, maybe a direct anticoagulant should be the first choice. But if your patient has a gastrointestinal type of tumor or genitourinary type of tumor, then maybe mindful and really think about the risk of bleeding. And if the bleeding risk is high, then maybe initiating them on an enoxaparin or low-molecular weight heparin to challenge them to anticoagulation may be desirable, because the direct anticoagulant seems to be making mucous membrane bleed quite a bit more compared to low-molecular weight heparin. So when do I avoid the use of DOAC? Well, I try to have a reflection about the underlying risk of bleeding of the patient. So if there's a prior history of major bleeding, severe bleeding, if there's a high-risk GI lesions, if the patient is thrombocytopenic, and if there's severe renal impairment or liver impairment, Child's pube C, for example, or B for certain of the DOACs, the patients are on dual antiplatelet. I try to clean that up if it's not needed. But in patients at a high risk of bleeding, I tend to challenge them to low-molecular weight heparin to begin with. And then depending on the course, then sometimes I do a transition to a direct anticoagulant. I look at the type of tumor. We mentioned that for edoxaban and rivaroxaban, the trials have shown that patients with gastrointestinal type of tumors had a higher risk of major bleeding, mostly upper GI type of bleeding. And therefore, I tend to be mindful of that from a major bleeding perspective. And we discussed that from a GI and GU cancer perspective, they are also at high risk of not major bleeding, but clinically relevant non-major bleeding. For example, patients with the bladder cancer coming into your emergency room department with hematuria requiring total bladder irrigation and 1 unit of packed blood cell still is an important bleeding, right? But it didn't meet the criteria for major bleeding. So I tend to be mindful of that. So if they have unresected intraluminal GI-GU cancer, I tend to challenge them to low-molecular weight heparin first. And if there's drug-to-drug interaction with DOAC, so obviously there's less drug-to-drug interaction with DOACs compared to vitamin K antagonists, but more so than low-molecular weight heparin because it's parenteral, of course. If there's strong CYP3A4 or strong glycoprotein P interaction, so if they're inducers, they could decrease the level of the different direct anticoagulants early on, maybe a high risk of recurrence. And there's strong inhibitors, then it'd be increased risk of bleeding associated with increased plasma concentration of the different direct anticoagulant, and therefore I would favor a low-molecular weight heparin in that setting. And there's a number of other things that one need to be mindful of. We mentioned cost, logistics, body mass index, able to tolerate PO intake. So all of these things need to be factors, but this is a little bit how I make a difference between choosing a DOAC or low-molecular weight heparin in my clinical practice. So the patient is started on anticoagulation for 6 months. We said indefinite or lifelong duration of anticoagulation. So the next question is, when do you consider half-dose anticoagulation versus full dose of anticoagulation among cancer patients? And is there any special dose type for GIGU patients with cancer? So I assume this question was related to secondary prevention. So the acute treatment for cancer-associated thrombosis is the initial 3 to 6 months. After the 3 to 6 months, the initial clot is cured. The rationale to continue anticoagulation is for secondary prevention, preventing a second clot from happening. If the underlying risk factors are still present, we tend to continue anticoagulation. If the underlying risk, if the risk factors are gone, like the cancer is in remission, there's no anti-cancer treatment, we tend to stop. So we need to have a reflection of what's the underlying risk, a little bit like what you do for patients with unprovoked or minor provoking risk factors after the initial course of anticoagulation. You have to try to judge what's the underlying risk of recurrence, and a number of factors are important. In the setting of cancer, we mentioned risk factors for recurrence. I'll show that in the risk factors of bleeding, but also it's important to have a reflection about the life expectancy in patients with cancer. So we used to think that continuing anticoagulation until death was the right thing to do. Some data in the past few years have shown that when patients are transferred to palliative care or hospice setting, then maybe continuing anticoagulation in these patients, especially if it's for secondary prevention, is causing more bleeding complication, not necessarily major bleeding, but clinically relevant non-major bleeding complication. And so we may be causing more harm than good at the end of life with our anticoagulants, and we need to be mindful of that. So we need to balance, it's the same exercise as what we did for the acute treatment. We need to balance the risk and benefit of extended duration of anticoagulation for secondary prevention. We need to be mindful that the case fatality rate, or the risk of dying from recurrent VTE or the risk of dying from major bleeding, is slightly different in patients with cancer compared to non-cancer. Remember, in the setting of non-cancer patients, the case fatality rate is threefold higher for major bleeding compared to risk of recurrence. It's not the same thing in patients with cancer. So the case fatality rate of recurrent VTE seems to be higher than the case fatality rate of bleeding. And that might be something to keep in mind when we make a decision about extended duration or not. We mentioned risk factors for recurrent VTE in patients with cancer. High risk cancer type, pancreatic, like our patient, for example, especially if it's metastatic. Advanced stage metastatic disease is another risk factor. Residual vein obstruction, pulmonary artery obstruction, we can have a discussion about it. It hasn't been shown to be an important predictor in non-cancer patients, but the SELECT-D second randomization of SELECT-D has used it, so we can have a reflection about that. Advanced age, previous VTE, the symptomatic event compared to incidental, and some biomarkers. And the same thing for bleeding, right? So unfortunately, it's somewhat similar to a certain degree, but unresected mucosal tumors, you need to be mindful. Metastatic disease, history of bleeding, hepatic renal impairment, thrombocytopenia, advanced age, frailty, end-of-life related issues. These are things that we need to put in a balance to decide on the risk-benefit ratio of extending duration of anticoagulation in that setting. So what type of data that we have? Well, we have really bad data, but we need to make that decision on a daily basis. So what do we have? We have 6 pieces of information, all of which are not the best, but we'll try to put that together to make a decision. The first piece of information is the DeltaCan study. This is an observational single-arm study of dalteparin, full dose for the first month, and then dose reduction thereafter, so 75% thereafter. Patients were followed for 12 months, and then the primary endpoint was to look at the second 12-month risk of major bleeding complication compared to the first 6 months. And you can see here that when you look at month 2 to 6 versus month 7 to 12, when you look at major bleeding on your left-hand side, there's no big difference. So the risk of continuing anticoagulation seems to be very similar after the second 6 months compared to the first one. And from a risk of recurrent VTE point of view, it is similar again, but remains high despite the fact that they continued anticoagulation. So indirect evidence saying that patients remain at high risk despite the first 6 months. Continuing anticoagulation with therapeutic dosing or intermediate dosing of low-molecular weight heparin seems to be beneficial in that setting. But remember, there's no comparator arm. It's a single-arm study, so no comparison. Same thing with TCAT. So this is with tinzaparin. There is full dose of tinzaparin, so 175 units per kilogram for 12 months, so no dose reduction. And similar thing, they were looking at major bleeding, comparing the last 6 months, the first 6 months. Obviously, these two studies excluded the first month because that's a high risk of both recurrence and major bleeding. But you can see there's no difference in the risk of major bleeding. Risk in the months 7 to 12 of recurrent VTE remains relatively high, despite that fact that they continue anticoagulation. Indirect evidence saying that maybe we should continue some form of anticoagulation. Low molecular weight heparin at therapeutic dosing might be something. Okusai VTE cancer also gave us some clues. Remember, Okusai VTE cancer compared edoxaban to low molecular weight heparin for management of cancer-associated thrombosis, but it didn't stop at 6 months. They continued to 12 months. So this is the second 6-month analysis of the study, and it showed, although there's a comparison between dalteparin and edoxaban, so therapeutic dose of DOAC, intermediate dose of low molecular weight heparin, although there's a comparison, there's no comparison compared to no treatment. But you can see again, indirect evidence saying that the risk of major bleeding remains relatively low, no difference between the two groups, and the risk of recurrent VTE remains relatively high despite anticoagulation. So again, some indirect evidence saying we should continue a little bit of something. The only study that really compared anticoagulation to nothing is the second randomization of the SELECT-D. So you know the SELECT-D because it compared low molecular weight heparin to rivaroxaban for acute treatment of cancer-associated thrombosis, followed patients for 6 months. They had a second randomization after 6 months, randomizing patients that had an index event of a PE or residual vein obstruction on baseline ultrasound to continue rivaroxaban 20 milligrams PO daily or switch to placebo. And you can see that for patients that were deemed to be at high risk based on residual vein obstruction or PE as the index event, there's a big difference in the risk of recurrent VTE between those that have continued on with rivaroxaban compared to using placebo. Now, you can see it's a very small number of patients, only 92 patients, because they stopped randomization because they couldn't include patients very well in the second randomization. Physician or patients have very strict opinions about if they should continue or stop, and therefore there was felt to be no clinical equipoise. But it seems to be safe. There was no major bleeding and similar risk of clinically relevant non-major bleeding. But this is evidence again that maybe therapeutic dosing of low molecular weight of direct anticoagulant may be beneficial in that patient population. There's about prophylactic dosing of direct anticoagulant. People from Norway did a prospective cohort study where patients after cancer-associated thrombosis and 6 months of anticoagulation were receiving apixaban 2.5 milligrams PO BID thereafter for an overall follow-up of 30 months. So you can see here that when you look at recurrent VTE, the incidence rate was relatively low, 1 per person month, and the risk of major bleeding was also low. Remember that there is no comparison, but this is reassuring data that maybe prophylactic dosing of direct anticoagulant may be helpful. So for the time being, we have data for therapeutic dose of low molecular weight heparin, therapeutic dose of direct anticoagulant, and prophylactic dose of direct anticoagulant. So we need randomized controlled trial comparing prophylactic and therapeutic dosing of anticoagulation in a setting of cancer-associated thrombosis for secondary prevention. Now, the EVE trial was presented at ISTH in 2023, published in the JTH this year. It's a small trial, Mayo-based trial, 360 patients. It was a superiority trial looking at clinically relevant bleeding, so major bleeding and clinically relevant non-major bleeding, comparing 2.5 milligrams of apixaban to 5 milligrams of apixaban. And you can see here that for their primary outcome measure, they didn't show superiority of apixaban 2.5 versus 5. But you need to be mindful that there's some limitation to the study. It was powered for only 70%. Yes, the event rates may have been overestimated a little bit, and the absolute difference between the two groups may have been a little bit generous. But you can see that the point estimates seems to be reassuring, and maybe there's a little bit less clinically relevant non-major bleeding with patients receiving 2.5 versus 5 milligrams of BID. There's no difference in major bleeding. And for their safety outcome or secondary outcome, when they look at recurrent VTE, they combine venous and arterial disease, and there was really no difference. So maybe some clues that for patients that are not super high risk of having venous thromboembolic disease that you may be concerned about bleeding, maybe reducing the dose to apixaban 2.5 BID may be desirable. There's an ongoing trial. The last patient follow-up will be in September 2024, probably presented at the American Society of Hematology meeting in December 2024. And that's the APICAT trial. It's a French-based, European-based study randomizing patients to 2.5 apixaban and 5 milligram POBID of apixaban. They have the proper power. It's a non-inferiority trial, and they have the proper power with a total number of patients of close to 1,800 to really definitively answer the question. So we will soon have data about when can we dose reduce patients. So how frequently do I dose reduce patients for secondary prevention? Well, there's another trial that will be coming out soon called the RENOVE trial. It's not in cancer patients, but randomized patients to prophylactic dosing of DOAC versus therapeutic dosing of DOAC. It's another French trial, non-inferiority trial. So we'll have data of that coming out soon. But for the time being, I tend to continue the same therapeutic dosing unless I have concerns about bleeding. And if I have concern about bleeding based on the EVE data, although not definitive, I tend to decrease the dose of the directal anticoagulant or dose of low molecular weight heparin to prophylactic dosing, but extrapolating data. But the APICAT trial will help us to do that. The second question that I guess was used or asked is, how do you dose adjust low molecular weight heparin for cancer-associated thrombosis? And I'm assuming this is in the acute treatment, and I'm assuming because in the United States you mostly use enoxaparin. Around the world, people tend to use dalteparin, tinzaparin a lot because it's a once-a-day full therapeutic dosing. And I would have to say that based on that, it's really individualized or a case-by-case basis. And there's rationale for both. And the reason why I'm saying this is because if you look at CLOT, so that's a landmark trial that showed that low molecular weight heparin was more effective and as safe as vitamin K antagonists. It's published in the New England Journal, but it was published in 2003, and that's the graph on the left-hand side. And that's full dose of dalteparin for the first month with dose reduction afterwards to 75% or intermediate dosing for a total duration of 6 months. And you can see that dalteparin was more effective, no difference in major bleeding, although it was in 2003, so prior to the ISTH major bleeding definition, but seems to be relatively safe. Now, cancer patients in 2003 and 2024 are very different. Therapeutics has changed. Patients are living longer. This is more complex. There's more comorbidities. So who knows if the dose reduction is still effective. So the tinzaparin group has done the CATCH trial, and that's on your right-hand side. So in 2015, they randomized patients to vitamin K antagonists or therapeutic dosing of tinzaparin, no dose reduction, followed patients for 6 months. The primary outcome was efficacy of risk of recurrent VTE, and they did not reach it. Relative risk reduction of 30%, but they didn't have the same event rates as they had in the CLOT trial, and the relative risk reduction did not reach statistical significance. But they did have statistical significance in clinically relevant bleeding, so a combination of major and clinically relevant non-major bleeding. So it's confusing a little bit because now you know that in 2015, full dose anticoagulation was not superior to vitamin K antagonists, but provided some benefit over safety. So there's not a whole lot of advantages to decrease the dose, because if anything, patients may be at slightly higher risk of VTE. But it's different with enoxaparin because it's between a BID versus a once-a-day injection, and that might have consequences on compliance and adherence. So what I tend to do when I use enoxaparin is I tend to use the therapeutic dosing for the first month, because we all know this is the highest risk of recurrent VTE, high risk of bleeding. The once-NOC trial, if you look at the different trials, the different arms looking at once-a-day BID or IV fractionated heparin showed a higher risk of bleeding, higher risk of recurrence in the once-a-day compared to the BID. This was, real-world data have shown some differences over time, but I tend to say, well, maybe we can continue on for the full dose for as long as we can to go through the high risk period, and then dose reduction may be desirable afterwards. I would feel comfortable with that afterwards. So really, it's an individualized approach to decide if we do it or not. Now, our poor patient is on anticoagulation long-term, and maybe I'll stop after the question so we can have questions. But unfortunately, he's noted to have an intracranial hemorrhage upon an emergency room visit due for persistent headaches. And then obviously you need to stop anticoagulation. When do you restart anticoagulation? And for that, it's really on a case-by-case basis. And there's a number of things that you need to be mindful of and include in your decision. So the first is the indication for anticoagulation. What's the risk of recurrence or the risk of extension or embolization? Is the index event a distal DVT for which you're not really worried about it? Is it a subsegmental PE for which you know there's a relatively low risk of recurrence? Is the time since the index event, does this bleed happen a week after diagnosis of bilateral lobar PEs, or is it 6 months down the road where you feel more comfortable in secondary prevention? CT imaging and MRI imaging will also be helpful to decide how old the bleeds are. This is important because he had persistent headaches. Maybe the bleeds have been there for a little while, and therefore that may affect the time in when you feel comfortable restarting anticoagulation. And the MRI may give you additional information with the T1 or T2 weighted images about the time since the last time. And then if you're not sure, serial imaging may be desirable to make sure there's no progression over time. And obviously, risk of recurrent bleeding has happened while the blood pressure was under control, and what's the volume of the intracranial hemorrhage. So a number of things need to be in place. But one thing that we know is that prophylactic dosing of enoxaparin or fractionated heparin can be used within a few days of having an intracranial hemorrhage. There's a small observational non-randomized trial looking at, I shouldn't say trial, study looking at unfractionated heparin at a prophylactic dosing, so 5,000 Q8, and they compared 4 versus 10 days following ICH, and there was no association with increase in hematoma expansion. So if the intracranial hemorrhage would happen right after the clot, the PE, let's say in a week or two, I would probably put an IVC filter, and I would feel comfortable resuming some form of prophylactic dosing of anticoagulation within 2 to 4 days following the ICH. And then based on that, then in discussion with a neurosurgeon, then we can slowly tailor the dose of anticoagulation. If the risk of recurrence is low, then I don't tend to put an IVC filter, obviously. And I would start prophylactic dosing maybe 4 days after the 4 to 5 days after the ICH, and then I would do serial imaging and then discussion with neurosurgery for when it is okay to resume full dose anticoagulation. If it's a larger ICH, so if it's more than 10 cc's or higher risk of progression because it's multilobar, for example, then I don't tend to use any pharmacological trauma prophylaxis. I'd put an IVC filters in the acute setting. I would not do anything if it's not in the acute setting, and I would have discussion of neurosurgery. Most clinical practice guidelines would suggest full dose or therapeutic dosing of anticoagulation within 4 to 8 weeks. But some studies have shown that up to 2 weeks is also no different than 4 to 8. So it really depends on how you feel about the underlying risk of recurrence. But one thing is for sure is that if you don't resume anticoagulation, systematic reviews and meta-analysis that's published in BMJ Opens sort of shows that there's more increased risk of overall mortality, increased risk of recurrent event, arterial or venous, if you don't resume some form of anticoagulation. No real difference in the risk of recurrent intracranial hemorrhage for those that have resumed anticoagulation. So obviously in a case-by-case discussion, I tend to want to resume some form of anticoagulation eventually, especially if the patient's at really high risk. If it's low risk, then you don't need to lose sleep over it. But these are the things that I usually consider. So the next question is, so right now we have vitamin K antagonists, we have warfarin, we have low-molecular heparin with enoxaparin, we have directal anticoagulant. I would probably assume mostly rivaroxaban and apixaban. We have edoxaban as well. But there's still an important knowledge gap for the management of cancer-associated thrombosis, right? We've mentioned that some of these tumor types are higher risk of having bleeding complication, GIGU. So it'd be great to have a molecule that is not associated with a higher risk of bleeding complication. The different molecules are injectables and daily injections, sometimes twice a day injections, or they're tablets, sometimes twice a day tablets. We know the adherence or persistence over time is not the best. So something that is monthly may be easier for persistence. They could get the chemotherapy, get their shot of the factor 11, 11A inhibitor at the same time and be anticoagulated for a month. We know that patients with cancer often have renal dysfunction, liver dysfunction. Low microwave heparin is a problem, and directal anticoagulant for patients with severe renal dysfunction. Hepatic dysfunction is a real problem for patients with directal anticoagulants because Child-Pugh C is a contraindication, Child-Pugh B is some contraindications for some of them. And we know that DOACs still have CYP and glycoprotein P drug-to-drug interactions. So there's a number of unmet needs with the current anticoagulation. And that's why factor 11, factor 11A inhibitors may be something to consider that may meet these unmet needs and maybe improve safety and efficacy of anticoagulation for cancer-associated thrombosis. So remember, I mentioned that tissue factor will lead to the extrinsic pathway. So the thing about factor 11 is they are not needed for hemostasis, but an important mediator for thrombosis. So if you have an injury, you would have overwhelming tissue factor, and that's on the right-hand side for hemostasis. You have overwhelming tissue factor that would lead to the common pathway, thrombin generation of fibrin. And because you have so much tissue factor, you don't really need the feedback inhibition, the feedback activation of factor 11 to generate or to include the intrinsic pathway. And therefore, factor 11 is not really used for normal hemostasis if you have an abrasion. But if you have pathological thrombosis, so you have a little bit of tissue factor from tumor cells that lead to activation of the extrinsic pathway, a little bit of thrombin, that's when the factor activation, the feedback activation by factor 11 is really important. And that generates a lot of thrombin, even if you don't have a whole lot of tissue factor to begin with. So that's the pathological clot. So the hope is to inhibit factor 11 or factor 11A, and therefore cut that feedback amplification of thrombin generation. And therefore, you have good enough coagulation cascade for hemostasis, but you've inhibited pathological thrombosis formation. And there are a number of factor 11, factor 11A inhibitors. They're described as antibodies or small molecules. So antibodies would be abelacizumab, for which there's 2 phase 3 trials, intravenous for first dose, then subcutaneous, rapid onset of action, but it's a long half-life. It's weeks, done monthly. And because it's parenteral, then there's no renal extraction, so no drug-to-drug interaction, no renal troubles, no liver troubles, and hopefully not associated with any bleeding, as we mentioned. For small molecules, you have ansudixian and milvexian that are in phase 2B and 3 trials. These are mostly oral, rapid onset of action, short half-life, so daily tablets or twice daily tablet, but are still dependent on renal excretion, and they may have some drug-to-drug interaction, but hopefully not associated with bleeding complications. So from a cancer-associated thrombosis perspective, we have 2 trials ongoing right now, ASTER and Magnolia, randomizing patients with cancer-associated thrombosis to apixaban or abelacizumab for 6 months, and for Magnolia for patients with GI and GU intraluminal tumors, randomizing patients to abelacizumab or low microwave heparin for 6 months with the endpoint of recurrent VTE. So it's a non-inferiority trials for recurrent VTE and superiority trials for major bleeding, clinically relevant non-major bleeding. So these trials are ongoing. I think they will be coming to an end in 2026. So we may have more data related to that in the near future.
Thank you, Dr. Carrier. This was very helpful. Thank you for everyone joining this morning.
Thank you for having me.